So it's really a great pleasure to be here with all of you today. This is just so exciting to me to start to put together this information that's been gathering over the last, I would say, 10 to 15 years. Let's see if I can find my slides here. What Dr. Henderson asked me to do today is to talk a little bit about the presentation of Ehlers-Danlos Syndrome, and I took the liberty of rolling into that the hypermobility syndromes as well, because many of the issues that affect Ehlers-Danlos Syndrome come up in many of the other hereditary disorders of connective tissue with joint hypermobility. I think one of the most important things to know about these disorders is that they are truly multi-system conditions. And although we think of the musculoskeletal system as the first organ of involvement, there is a plethora of other manifestations. And often what happens when these patients come to medical attention, there are so many different organ systems involved that the physicians who see them say, this just can't possibly be true. Therefore, the patient must not really be sick. And I cannot tell you how many patients I've seen who've had that experience and who've had it time after time after time over a period of 10 to 15 years before they finally come to a diagnosis. So musculoskeletal, dermatologic, neurologic, cardiovascular, gastrointestinal, and perhaps even immunologic manifestations are common in Ehlers-Danlos syndrome. Now, Brad Tinkle is going to speak about the diagnostic criteria and means of diagnosis a little bit later in the day. But I'm just listing the different types of Ehlers-Danlos syndrome on this slide just to get it out on the table. The classical form used to be called types 1 and 2 in the old nomenclature, and we know that this type is caused by mutations in the type 5 collagen genes, alpha 1 and alpha 2 chains. But there are definitely patients and families in whom the classical type is present who have a gene other than the collagen 5 genes, and that gene or genes has not yet been identified. The genes involved in the hypermobile type used to be called type 3. Those genes are unknown. The vascular type involves type 3 collagen, which is the major collagen of the blood vessels. And the less common forms, the kyphoscoliotic, arthrochalasia, and dermatosparaxis type, are caused by lysyl hydroxylase mutations, type 1 collagen mutations, and mutations in the procollagen and peptidase. Now, a recent nomenclature I saw lists tenascin X deficient Ehlers-Danlos syndrome as a separate type. Some people roll it into the hypermobile type. It's a very rare form of Ehlers-Danlos syndrome, and we still have a lot to learn about that particular type, but really only 1 to 5% of patients who look like the hypermobile type have tenascin X deficiency. So when we're assessing a person with hereditary disorder of connective tissue and we want to know, are they hypermobile, one of the first things we do is look at the Beighton score. And the Beighton score is a 9-point scale, and the patient gets 2 points if both of their elbows are hypermobile, 2 points for hypermobility of the fifth finger metacarpal joint, 2 points if the thumb both thumbs are able to touch the forearm, and 2 points for the knees, 1 point each side, being more than 190 degrees in recurvatum. And then there's 1 point if the patient is able to put his or her hands on the floor with the palms flat and the knees straight. Now, Dr. Rodney Graham has also published a questionnaire which he says works almost as well as the Beighton score. he says this has 84% sensitivity and 87% specificity. I see Dr. Tinkle shaking his head over there. But it's a good way to start. If you're trying to assess, you've got somebody on the phone or you're not able to actually examine them at the time, you can ask them these 5 questions, and if they're able to answer in the affirmative on 2 of them, there's a pretty good chance there's an underlying connective tissue issue going on. So the questions are, can you now or could you ever place your hands on the floor by bending forward with your knees straight? Can you now or could you ever bend your thumb to touch your forearm? As a child, did you amuse your friends by contorting your body into strange shapes, or could you do the splits? And as a child or teenager, did your shoulder or kneecap dislocate on more than one occasion, and do you consider yourself to be double jointed? So 2 or more of those is a pretty good indication of joint hypermobility. Now, Dr. Graham is a rheumatologist, and he makes a distinction between joint hypermobility and the joint hypermobility syndrome. So he defines joint hypermobility as the presence of a Beighton score of greater than or equal to 4, and he defines the joint hypermobility syndrome according to the Brighton criteria. And it's very unfortunate, in my mind, that Beighton and Brighton sound so similar to each other, because it's really quite confusing. But there we have it. That's it. Professor Beighton defined the Beighton score, and the Brighton criteria were defined in the city of Brighton. So there it is. Dr. Graham has presented several times in the recent years that the Ehlers-Danlos syndrome of the hypermobile type and joint hypermobility syndrome are one and the same thing. So for joint hypermobility syndrome, the major criteria are the Beighton score of greater than or equal to 4 and the presence of arthralgia for greater than 3 months in 4 or more joints. The minor criteria are listed here, and Brad will go over these a little bit later, so I'm not going to spend a lot of time on this right now, but they involve some other issues besides strictly the hypermobility. So the presence of joint pain, spondylosis or spondylosis and spondylolisthesis, dislocations and subluxations in more than one joint, things like epicondylitis, tenosynovitis, and bursitis, the marfanoid habitus, skin involvement, eye signs, and varicose veins, hernia, or uterine or rectal prolapse. And the Brighton criteria for joint hypermobility syndrome includes 2 of the major criteria, 1 major and 2 minor, or 4 minor criteria. And if you have somebody who has an unequivocally affected first-degree relative, 2 minor criteria suffice for diagnosis. So I'm going to give you a list of the kinds of things we see in the various organ systems. Time is short today, and we're all going to be kind of trying to present a lot of information in a very short period of time. But what we want to do is just try to get this information into everybody's consciousness, the big picture, and then we'll have an opportunity to discuss them at a later time. So for the musculoskeletal system, we're looking at joint hypermobility with subluxations or dislocations. These patients are predisposed to tendon and ligament rupture. They develop stress fractures. I believe that osteoporosis and osteopenia are more common in this population than they are in the general population. They develop degenerative disc disease, meniscus tears, chronic pain syndrome, and myofascial pain. And all of these things can lead to serious disability. Pain is a major feature of Ehlers-Danlos syndrome. This has been published now in several peer-reviewed articles documenting that pain is a major manifestation of EDS. Headache is a major source of pain, and this can be due to migraine, low pressure, high pressure headaches. Myofascial pain can contribute to the headaches, as can sinus pain, temporomandibular joint issues, and dental pain. In terms of the musculoskeletal pain, we know that joint laxity predisposes to acute injury, and that muscle spasm in response to that acute injury may be a cause of pain, or it may occur as a means to stabilize the unstable joints. In addition, myofascial trigger points develop in response to joint laxity, and we may get neuropathic pain as a result of nerve impingement from disc disease or from the joint laxity. Okay, moving on to dermatology. We have soft, stretchy, translucent skin which bruises easily and demonstrates atrophic scarring. You see here on the left the atrophic widened scars of a patient with EDS, the stretchy skin, and the strii atrophica. Now, we're going to spend most of today talking about the neurology involved in EDS, but it includes the issues around headache, spondylolisthesis, craniocervical instability, and cervical instability, Chiari malformation, frank Chiari malformation, and low-lying cerebellar tonsils with increased intracranial pressure, and also CSF leaks. Dr. Posinki will be discussing autonomic dysfunction, including the postural orthostatic tachycardia syndrome, neurally mediated hypotension. Sleep disturbances are very common in these patients, as are gastrointestinal mobility disturbances and difficulty with temperature regulation. In the cardiovascular system, we see mitral valve prolapse, aortic root dilation, which does not usually progress to a serious or life-threatening situation. Aneurysms are present in the vascular type of EDS, and Dr. Tinkle will discuss this in a little greater detail. Venous insufficiency and also fibromuscular dysplasia may be seen in these patients. In the GI system, we see hiatal hernias, gastroesophageal reflux. Chronic abdominal pain can be a major, major problem. Gastroparesis, which is subsequent to the autonomic dysfunction, with chronic nausea and vomiting, constipation, actually can be life-threatening. Some of these patients have very, very serious constipation. Several patients, to my knowledge, have had to have colectomy as a result of their constipation. So that's the degree of severity we're talking about. Irritable bowel syndrome, and also malabsorption. So that can result in malnutrition kind of situation, and all of the multiple consequences of low ferritin, low vitamin D, and I believe there may be, we don't have data on this yet, but an increase in sensitivity to gluten in this population as well. So the gastrointestinal pain in EDS is a consequence of the dysmotility, esophageal spasm, the GE reflux. The constipation can be quite painful, and the irritable bowel syndrome. There's also a phenomenon of sphincter of Oddi dysfunction, which can be difficult to diagnose and very difficult to treat. And Dr. Posinki recently brought to my attention abdominal wall hernias, which may be very subtle and difficult to pick up by conventional diagnostic means. Finally, in the immunologic arena, we have more patients with common variable immunodeficiency than we would expect by chance in this population, and multiple allergies are extremely common. There's also a suggestion that mast cell activation disorder may be more frequent in this group of patients, and we're in the process now of collecting data to be able to give specific percentages for all of these things. So I propose that joint hypermobility syndromes are much more common than we think. Dr. Graham and his colleague Dr. Hakim published that in the United Kingdom, up to 45% of all patients referred to general rheumatologic clinics satisfy the Brighton criteria and may therefore be said to have joint hypermobility syndrome. So this is a quote from their paper saying that this is a very common at-risk phenotype in the community at large. Albert Schweitzer said that pain is a more terrible lord of mankind than death itself. And I think it's really important for us to get the word out that pain in Ehlers-Danlos syndrome is not just EDS, that the pain in EDS has its origins either in musculoskeletal, gastrointestinal, or neurologic dysfunction. And while EDS predisposes to certain kinds of pain, it does not cause pain in and of itself. So our goal here is to really ferret out what are the underlying causes of the pain and the dysfunction, disability that our patients experience, and try to be at the vanguard of finding rational approaches to deal with these various issues that can be so terribly disabling. So I'd like to thank Ms. Jessica Adcock, who sees our patients with us. She's a genetic counselor par excellence who will be presenting to you later. And I appreciate so much my colleagues, Dr. Henderson, Posinki, and Gerwin, mentors Graham and McCusick, and our patients and their families. Thank you for your attention.
Any questions for Clair? All right, time for questions. Sorry.
Do we have time for questions?
Yeah.
Do you have any thoughts on what the pathophysiology of the loss of bone density of these folks might be? I certainly agree with you that they seem to be predisposed to bone loss and osteoporosis. Do we know anything about why?
I think it must have to do with the intrinsic collagen matrix.
Which are the genetic tests that you routinely do on these patients, or do you just diagnose clinically if it's very obvious?
So 90% of the time I'm just doing a clinical diagnosis. If I have a high suspicion for the vascular type of Ehlers-Danlos syndrome, I will send the molecular testing off for type 3 collagen. And I guess if there's a high suspicion for one of the rarer types, like the arthrochalasia type or the dermatis thoracis type, we would look at type 1 collagen as well. But because the type 5 collagen gene mutations are only present in about half of the people with the classical type of EDS, if you send the mutation testing off and you find a mutation, it confirms your clinical diagnosis. If you don't find a mutation, you just say, well, they're one of those people in the other half. So it's not that helpful. It's a very expensive test. The insurance companies don't like to pay for it. Roger.
In my experience, I think the issue is it's never very obvious. You know, I came at this thinking it was just young, very lithe girls, and when you really look at it, you have to do the testing and ask some of the questions, or you'll never find it, and you get surprised repeatedly by someone who you would swear was big boned and would not be flexible. It's just amazing things, and they're suffering.
Yes. We have, you develop kind of an index of suspicion, and Jessica and I also see the cancer risk assessment patients at Greater Baltimore Medical Center. And we have a review of systems checklist that we ask them to fill out before they come in. And she and I have gotten pretty good at knowing who's going to be hypermobile based on their review of systems that they fill out. And we're actually thinking about putting a request into our IRB to screen those cancer risk assessment patients for joint hypermobility, just to see, in a completely separate population who's not coming in for that issue, how common is it in the general population? Because you can tell if people have these gastrointestinal issues, if they're reporting sleep disturbances and temperature instability, we can say with pretty good odds that they're going to be hypermobile as well on exam.
Yeah, I mean, I think I learn from these patients every single time they walk in just by the pain diagram they fill in. And have you noticed that there's a racial predisposition from one race type to another? For example, I mean, maybe just because we're in the Midwest, so we see an overwhelming white population. Maybe that's where I just want to see people across. Have you seen people from other racial backgrounds, having a high preponderance of this? Second, is there a gender preponderance as well from the genetics point of view? I mean, in our practice, the vast majority of them actually happen to be white, blonde, blue-eyed females. I mean, is that?
That's probably the Midwest. So, but we see mostly Caucasian women, and I don't know. I've seen some families who are African American, but by and large, really, the vast majority of our patients are Caucasian women. These are autosomal. The classical hypermobile and vascular types of EDS are autosomal dominant disorders. So that means there should not be a difference between the proportion of men and women affected in families. But I think it's a sex-limited condition, and I believe that the hormonal influence of testosterone and strengthening the muscles helps to mitigate the joint hypermobility in men. And so they do not suffer from the severity and the multiple musculoskeletal issues that affect the women to a much greater degree.
Claire, I would just add that being in D.C. with a really cosmopolitan patient population, I've been really amazed to see this in every demographic group you can think of: the Asians, the Middle Eastern, the Mediterraneans, the African Americans. So it may have to do with where you're drawing your patient population from.
Yeah.
That we think of it mostly as a Northern European Caucasian issue.
Right.
Actually, I think Dr. Graham makes the point that hypermobility is actually more common in Asia, in Asians and African Americans. Although the patient population I see is obviously similar to yours.
And Claire, do you have an idea of how many people would have a positive Vagus score but be clinically well or normal?
So that's one of the reasons we'd like to do this this survey among the cancer risk assessment patients. The other way to do it would be to look at family members of the people who come seeking help because of their symptoms. I think there are many, many people out there who are hypermobile and who do not develop these serious complications. And one of the really big things I think we need to try to figure out is what are the triggers? Why do some people become ill and others remain perfectly well?